Hello, everyone. Good morning, good afternoon, good evening, wherever you are in the world. Welcome to today's ICP webinar. We have an excellent presentation today. So we're looking forward to having you be a part of this process with us. Today, we will be going through the healthcare for older adults in Latin America. This is the second of our health series, and we look forward to having you in this process with us in this conversation. My name is Dr. Dominique Eugene. I am one of the board members, and I'm also the webinar chair for the International Council of Psychologists. I am speaking to you from Abu Dhabi in the United Arab Emirates. Our speakers today is Dr. Annabel Gutierrez Torres and Dr. Sara Solis. The moderator will be Dr. Swati Bajpai, forgive me. For those of you who do not know about the International Council of Psychologists, the host for today's organization will be focusing on information that might be relevant to you. Please be mindful of any questions that might come through. We will have all the questions geared through either the QA section or the chat. We'll be monitoring as best as possible. Please also note that membership in the ICP is open to all, and we invite you, member or not, to join us for our conferences and our webinars. You can find information about the web on ICP through our link. Before we begin today's webinar, there are just a few housekeeping comments. Please ask questions in the QA function on your screen or via the chat. We will try to get to all questions during the discussion. Second, we will automatically send attendance certificates to everyone who is with us in the meeting for at least 40 minutes. We send the certificates to the names and emails we have on screen for you, the one that you use to register for this webinar. So if you are using someone else's computer or have a different email from your login, please send a separate email indicating how you are watching the ICP, how you are involved and how you're watching this through the icpinfo@gmail.com. I'll also put that information in the webinar in the chat. Now we would like to turn it over to meeting over to Dr. Swati Bajpai, who will introduce the speakers.
Thank you, Dominic, for a wonderful brief description of ICP. So I welcome you all to our ICP Health series. This is today's our webinar number 2. So for all the new participants who have not aware of the health series, ICP Health series, so it's an exciting series which is themed at Unity in Wellness, Navigating Global Health from the Lens of Equity. So our first webinar series was from the speakers from Africa, and today we have 2 wonderful speakers from Latin America. That is Dr. Annabel Gutierrez Torres and Dr. Sara Solis. So without further ado, I would like to introduce our 2 speakers. So both Dr. Gutierrez and Dr. Solis are geriatricians from Mexico. Dr. Gutierrez has received his medical school training from Monterrey Technological and Higher Education Institute. He has experience in social service, where he worked in a rural marginalized community in Chiapas, Mexico, working with partners in health and studying global health and social medicine. And Dr. Sara Solis received her medical school training at the University of Juarez of the state of Durango, and her training in geriatrics at the Autonomous National University of Mexico. And she's working in Mexico City as a clinician and a researcher. Currently, both of them are Global Brain Health Institute Fellow at the Trinity College, Dublin. So I welcome you both by saying hola. That's all I know from Spanish language. So I hand over to Dr. Annabel to start the webinar.
Hi, hello. Thank you so much for the invitation. We're really glad to be here. As Dr. Swati has kindly stated, my name is Annabel Gutierrez and I'm a geriatrician from Mexico. So I want to talk to you about how Mexico has become a country that has increasing life expectancy. And since this is a health equity seminar, I wanted to relate that with the income in the that we have in the country. So as you can see, we have data that dating back all the way from the 1800s, when the income, as far as the income has been increasing, the median income per capita in the country, so has the life expectancy. So in the 1800s, we were as low as we aged really low, but as long as we began to have more income within the country, you can see that the life expectancy starts booming. So these are the bubbles that a program called Gapminder has. And you can compare us with the different countries that are in the different bubbles. So the big one is India, the big red one, and the other big one is China. Each color is also from the different continents. So you have Africa, you have America in green, and Africa in red. So what you can see is that as far as the income has been increasing, so has the life expectancy. This is the last data on the program, Gapminder, and it has until 2018. So you can see that life expectancy is over 70, reaching to 75.5 to the year 2024. So why is this important? Because now there is a demographic shift that we are having in Mexico, as with many other industrialized countries. Mexico is a low and middle income country, but we are having this shifting into a high income country, but we still have the diseases of a low and middle income country. All the while, our life expectancy is changing and the population pyramid is changing, because you can see in 2010, we have here in blue the different ages. So we have 0 to 4 and 85 plus, how we used to have more young people being born and more people within that age group. But then in 2050, what is going to happen according to the projections? There's going to be a total turnover when people who are older will be the biggest part of the population and people who are younger will actually be scarce in Mexico. So this has a lot of impact in the healthcare system. Why? Because now you are taking care to an entirely different kind of diseases with older patients, as they have to be taken care by specialists, preferably a geriatrician such as myself and Dr. Sara, who know how to manage these patients in a more holistic approach and integrating all the different medical specialties in one single team. So this is quite a challenge for the healthcare system. So out of the 126 million people residing in Mexico, right now, over 50 million are age 60 or older. This constitutes about 12% of the total population. And by the year 2050, this percentage is going to raise by 20 to 23%. So as you can see, there's going to be a huge change in demographics that is called by some the silver tsunami. And what is happening with this population? A really important thing that we have in Mexico is that the division between those who are economically active and those who are not. Why? Because that impacts the way the healthcare they get. So as far as the economically active population, the population older than 60 years compromises 10% of the total economic active population. However, it is really important that 70% of the economically active older population is engaged in the informal sector. And this will have huge importance with the type of healthcare that they receive and the inequities within this, as we will see further. Also, because the population has been aging, there has been a lot of government programs that try to help the older patients. So even since the year 2010, there started a program that gave pensions to those aged 67 plus. So 68 years and plus, regardless of your economic status, regardless of your whether you're a man or a woman or wherever you live, the government will give you a bi-monthly income. So the new government, in order to give this support to a broader range of people, they diminish the age from 67 to 65 plus. So now any older adult 65 years and older in Mexico gets this bi-monthly pension. And this there has been some studies as to whether this actually helps the older population or not. Sadly, this doesn't help because there hasn't been a change in their economic, even though that they receive the help, that in the short term, they might feel relief in the economic pressure. on the long term, there hasn't been any statistical changes in important decisions. And there has been some spillover when the people receiving the pensions, these older patients, they usually save it and they don't use it on themselves. They use it on their grandchildren in order to give them education and in order for them to have a better life. But again, this spillover is really minimal, and in the end, is not a program that is going to be viable on the long run. So this is a huge important for the Mexican healthcare system as well, because currently Mexico invests only 5.4% of its gross domestic product in health. And if you compare it with the other countries of the Organization for Economic and Cooperational Development, the OECD, they invest 9.2%. So it's no surprise that the Mexican healthcare system is usually underfunded, understaffed, and overcrowded. And you could see this, for example, in the pandemic. The pandemic was a huge example of how the Mexican healthcare system is not prepared for this kind of large-scale catastrophes. You can see that because, for example, Mexico, to this day, remains the #1 country with healthcare professionals dead throughout the world. Even more so than Africa and different countries, Mexico has the #1 death in all healthcare workers during the pandemic. And this was because of, clearly, as you can see, because of the underfunding of this healthcare system. So how does the healthcare system work? Well, it's actually quite complex because, as you remember when I told you before that it's important the kind of economic sector that the people are in, that's because that will depend on the kind of healthcare they get. So really broadly speaking, you have two large blocks of healthcare: public healthcare and private healthcare. What happens in private healthcare? You have individuals and you have the employers who hire the private insurance companies, or even the individuals themselves go directly to a healthcare provider and pay out of pocket. But what happens? That you have here a really special population, or part of the population that is economically active, but also that has the economic capacity to be paying these healthcare providers in order to get their healthcare. So what happens when you start paying for your healthcare? That health no longer becomes a human right. It becomes a commodity that only those who can afford it can get it directly. So this is the private healthcare. But then in the public sector, it gets more complicated, because in the public sector, you have the Social Security and you have the Secretary of Healthcare, that it's different according to the type of economic activity you are. So if you are in the formal economic activity, then you can apply to Social Security with IMSS, Instituto Mexicano del Seguro Social, when there is a contribution from the government, a contribution from your employer, and a contribution from you yourself as a worker. But then in that Social Security, it depends on whether, if you are in the formal sector, in which part of the formal sector you are, in order to see which kind of healthcare you get. For example, if you are in the private sector, in a private company, and your employer pays your insurance, then you will be part of Instituto Mexicano del Seguro Social, which you can see here in the image, IMSS, IMSS. That would be one huge part. Actually, the largest part of the healthcare system is run by this. But then if you are a worker for the state, you wouldn't be able to get IMSS. You would get ISSSTE, Instituto de Seguridad Social de Trabajadores del Estado, which is the same, but for state workers. And they have different funding, and they have different healthcare. They have different hospitals. So this is ISSSTE, ISSTE. But then if you work for the private oil company of Mexico, that is a national company, then you would get PEMEX, which is PEMEX. That would be a different hospital, different healthcare, and different benefits. And then if you work for the Navy, if you work for the military, you each get different hospitals and different healthcare. And all of these IMSS, ISSSTE, PEMEX, SEDENA, all of these different healthcare systems, they have their own suppliers, their own hospitals, their clinics, their own medical institutions, and the end stage user are the workers of that formal sector the families of that formal sector and the pensioners from those formal sectors. So if you are in the formal sector, then you are in any of these public formal sector kind of healthcare. But what happens with the second largest block of the population? That is the population that doesn't have any kind of health insurance. Why? Because they are in the informal sector. So for this, there was a secretary made, that is the health secretary, that tries to cover what is this huge amount of the population that are in the informal sector and don't have any kind of insurance. So there used to be a program called Popular Insurance that was started by Julio Frank, who is now the dean of the University of Miami, when all these people who didn't have any kind of healthcare would be taken care by the government with a government contribution that was a large contribution done federally and a smaller contribution done by the state government. So this was the Seguro Popular, the popular insurance. And even though with all these caveats and with the different issues that this could have, it worked and it covered for this population, and it prevented a really important thing called catastrophic healthcare expenses. When people who were in this sector, in the informal sector, and didn't have any kind of social security, they would have to be forced to go to the private sector. They would have to pay out of pocket, and they would be paying for diseases such as cancer, chemotherapy, all out of pocket, and it would be catastrophic for them. When they, of course, they might be able to afford it, but then they wouldn't be able to pay for the other basic necessities. So this would be considered a catastrophic healthcare. So the popular insurance in this was really good. It used to take care of people living with cancer and also end-stage kidney disease. And this was done by the state and the federal government working together with different funding. But then what happened when the new government came? This actually stayed through different governments. It stood with one government. This was inaugurated by one government with the President Fox. Then it went over with President Calderon. And then it went over with a different kind of party, the previous ruling party, PRI, with Peña Nieto. So 3 different presidents ruled by this, and it worked. But then the new president came, and he destroyed all this healthcare system without a real plan to change it. So all of this population that didn't have any kind of social security, all of a sudden they will promise that they would be able to get any kind of healthcare for free. But then all the different institutions from the formal sector of the economy, they couldn't give their healthcare to these patients. So even though it was a promise, it wasn't realized. This was the original plan. It was called INSABI, the Healthcare for Wellness Institute. So they used to have, they promised that they would give treatment, diagnostic tools, they would help healthcare workers and hospitals to cover all this sector. But since there wasn't any real plan, this started to fall apart. People started to die because there was a huge lack of medicines. There was a huge lack of professionals. And instead of favoring the national doctors, they brought doctors from Cuba that didn't actually knew the national healthcare plans, so they couldn't help out as much. So this was a huge crisis in the healthcare system because it changed overnight without any plan. And currently, with the new government that is going to be a continuation of the current government, there is still no plan but to do another reform for the informal sector. So as you can see, there is a lack of a universal healthcare system for Mexicans, and this leads to a huge amount of inequities within health. How about mental health? That's why we're here. Well, as you can see here, this is a graph with the different population and the psychiatrists that they have per habitant. And this is an old graph of 2005 from the WHO. So as you can see, in countries that have huge populations, such as the United States, they used to have per 1 million inhabitants, 13.7 psychiatrists. In Argentina, 13.2. Canada, 12. Germany, 11.10, Brazil 4.8, Spain 3.6, and Mexico 2.7 for the population almost as large as the United States. And then if you go even further, another huge inequity is that the kind of healthcare you get depends on when you are. As you remember me saying before, the federal government covered a huge part of this healthcare system, but then came the states. So a rich state such as Nuevo León, Monterrey, which I work in, and a poor state such as Chiapas, Mexico, wouldn't have the same access to healthcare, but also they wouldn't, because of the fundings, because of course one state would have more money and the other one would have less money, and then they would have less hospital, but also less professionals in healthcare. If you can see here, this is a graph that graphs the psychiatrists per 100,000 inhabitants. And per 100,000 inhabitants in Mexico City, you have about 18.86 psychiatrists per capita. And if you compare it with Chiapas, the state that I used to work with during my social service, you cannot even have one. You have 0.54. So this makes a huge inequity to the healthcare, where you have a centralized healthcare system and a centralized professionals that are only in the urban areas, but the rural areas such as Zacatecas, Chiapas, Tlaxcala, Guerrero, Hidalgo, Oaxaca, Veracruz, do not have enough psychiatrists to tend this population. So this becomes a huge inequity. So as of 2023, there are 357,44 psychology professionals in the country, of which 70% are women and 29% are men. But currently, our country has a total of 129.5 million inhabitants, according to the last census. And based on the number of psychologists, each one should serve over 130,000 people. So as you can see, these inequities have been across the country for a long time, but they are currently exacerbating, where more and more healthcare professionals are concentrating in the more urban parts, and the rural areas are deprived of psychiatrists and psychologists. So these inequities in healthcare have made for the elderly population, especially vulnerable, the especially vulnerable ones, to not be able to get the healthcare that they need or that they deserve. And as I was mentioning before, when you start to have all these inequities, then health no longer stops being treated as a human right. It starts being a commodity, because you will not get the same healthcare in the city that you would get in a different state. So that gives the wrong idea that some lives are more valuable, or some diseases are more valuable than others, which of course we all know that isn't true, that in the end health is a human right, but there are huge gaps, and there is this lack of universal healthcare system that are really impacting those who are most vulnerable in Mexico.
Hello, everyone. My name is Sara Solis, and today I will continue with the talk that Aniva was giving you. So when we talk about the Mexican situation on aging, we can realize that Mexico is not in very good position compared to other countries. This is a study that was conducted in 25 countries, in which Mexico was compared to them. And as you can see, older people in Mexico, yes, they can have higher rates of employment, but as we discussed before, this is because of the economic situation of the country. But they also age with worse independent and healthy aging. So that means that the situation is not very good. And this is very related with the problems that we are going to face as dementia and other problems related to brain health. So talking about dementia, in Mexico, mild cognitive impairment has a prevalence of 18, and dementia has a prevalence of 8 to 10%. In the country, as in many other countries, especially countries that are low and middle income, we have many variables that are related to this, especially depression, cardiovascular diseases, and other non-communicable diseases. This is very frequent in countries like Mexico, but also in all the region of Latin America. Mexico in 2014 created its first dementia plan. However, no budget was allocated to this. And in 2024, the plan was renovated. However, we still have no budget allocated to the National Dementia Plan. And that means that we are building a slow progress to the attention of dementia and other cognitive problems. As Aníbal was saying, mental health is very undervalued in Mexico, and we need to allocate more efforts to this. Regarding dementia, mental health, and other diseases, in Mexico, most of the efforts are made by individuals. So there's no institutions making actual efforts or associations to promote programs that are at national level. So everything is very local and very different from the context that is, for example, from the urban to the rural sector. So when we talk about the acceptance of dementia, this is published by the Alzheimer's Association, and they talk about the 6 stages of acceptance of dementia in many countries. Of course, the first one will be when we ignore the problem, and then we gain a little bit of awareness, then we can build some infrastructure around dementia and other cognitive problems. We can create advocacy efforts, and then the ideal will be that everyone can have dementia plans that can promote the normalization of dementia. And by normalization, we mean that dementia is considered a disease in the community, and the community understands it and participates with the people living with dementia and other cognitive declines. However, no country in the world has reached the 6th stage of normalization. There's no countries that are in that stage. And in countries in Latin America, especially in Mexico, you may say that, okay, we are in the stage 5, no, and the dementia plans. However, as I mentioned before, we don't have a national budget for this. The efforts are very local. Everything is like very individual. So that means that we are not yet there. And that we made between some awareness and advocacy efforts that we are building. So where is Mexico in all this? Mexico has one of the most important aging studies in Latin America, that is the Mexican Health and Aging Study, has 5 waves, and is these 5 waves until 2015, the cognition was included. Before this, we didn't have any information about the participants. And from 2015, we started to measure cognition. That means that in 2015, Mexico started to create a research and some awareness about this. And when we talk about the inclusive of the environment, as you may know, there's an initiative by the WHO called Global Network for Age-Friendly Cities and Communities. That is mean that the cities and communities are inclusive with older people, and that they can hold the people living in their own space, and also they can promote them to be part of the community. As you can see, the efforts are very big in Europe and North America, like Canada and USA. And in Mexico, we have some efforts, but again, they are very local. As you can see it would be the middle of Mexico, you have a little a big conjunction of red dots. That means that these cities are trying to be part of this global network of age-friendly cities. But as you can see, this is just a small effort in the whole country, which is very big. And we don't have any program that promotes this in the whole country. So yes, we are being part of creating some infrastructure for the inclusion of people living with dementia, and also for the inclusion of all people in the community. But again, these efforts are not enough yet. This is a study that it was published about Latin America, and it highlights the different challenges that Latin America has. As you can see in the first square, there are the current challenges. And there's where Mexico is, because Mexico currently has a lot of inefficiencies, like we were talking before, but also we lack about a long-term care. That means that we don't have any institutions that is going to take care of people living with dementia or people living with cognitive decline, and the mental health care is also lacking in the country. Also, we have huge disparities in the socioeconomic status and social determinants of health, as Aníbal was saying. And we also have a lot of gender bias burdens, meaning this because most of the caregivers for people living with dementia and other mental health problems are women. And that limits the efforts that women can produce in society, and also that increases their job. Also, we still have a lot of stigma for patients living with dementia and their caregivers. The challenges or the short-term actions that we can take as a country that is a middle-income country like Mexico, and in general the region of Latin America, is that we need to identify the needs of the caregivers. We need to provide evidence-based local interventions that can be generalized to the whole country, and we need to promote the community and the integrational support of people living with dementia and other cognitive declines. And in the long term, it would be ideal that we can, and ideally in the whole world, but that would mean that we are going to be in the stage 6 of acceptance of dementia. So since no country is there yet, we are aiming just to create a brain health regional program in Latin America, so we can start to produce long-term goals and long-term responses to these problems. Mexico and Latin America also needs to adapt and implement collaborative care models for the people who are living with mental health problems and dementia and cognition. So how is the care in Mexico for people living with dementia? Well, the optimal care will be that the patient presents to the GP, and then they communicate their problems. And then the GP will do an initial assessment, and they will refer it to maybe a more specialized doctor. However, in Mexico, we are still stuck in the first part, in which one, the patient might not present with the GP because they may think that is normal for aging, or also they have a lot of stigma around problems with cognition. So they will say like, oh, I don't want to talk about this with my doctor. And when some of them present with the GP, okay, they might receive an initial assessment, but the quality of this assessment is usually not good, and usually it's not enough. And then when they are referred to a specialist, well, as Anibal was saying, since the healthcare system is very fragmented, they will get lost in the system, most of them. So the ones who reach the later stages of the pathway of care will be the less of the patients who are living with dementia. So that means that Mexico is currently focusing its efforts in the primary health care, trying to raise awareness in the population and trying to reduce the stigma, and also trying to make the primary healthcare being good, so that the patients that actually reach to the GP, they will receive attention that is significant, and they provide more attention to the patients. So going back about where is Mexico in the acceptance of dementia? Well, you can see that we, as a country, as a region in Latin America, we are not ignorant of the problem, and we have some awareness. Some cities and some parts of Latin America are building them in dementia infrastructure, and also are building infrastructure that is age-friendly. However, you saw on the map that the efforts are very individual, and there's no national effort towards this. We are building some advocacy efforts in the country and in general in the region. And if you remember the table that I presented before, we are trying to focus to build these efforts in a regional way, so we can attack the problem of brain health since the perspective of Latin America. Yes, many countries in Latin America, including Mexico, possess dementia plans. However, the implementation of these plans is not the best, because we don't have budget for it, because our healthcare system might not be ready to it, and because also our population are still in the part in which they are gaining awareness of the problems around cognition and mental health. So although we have a dementia plan, and although we have some efforts towards this, we are still in the phase in which we are building our path to the normalization of dementia and other mental health problems. And as conclusion, like many other countries, Mexico is in the process of improving the care of all the population, the care of people living with dementia and other mental health problems. However, we still need to create specific actions that include a customized approach for the different diseases, for the different populations that we have in the country. Remember that Latin America is a very rich country in ethnicities and also in big disparities. So we need to create customized efforts for each country and each region.
Thank you so much, Sarah, Dr. Annabelle and Dr. Sarah, for giving such a in-depth situation of healthcare system in Mexico from the general perspective to a dementia perspective. So it was really interesting. So if I ask you a few questions is, what sectors are important to address the human right issues of access to mental health care? And is this a political situation in Mexico, or is it something that the psychology professions can do? Is there anything, both of you, any of you can answer that? What do you think? What is your perspective on that? And what sectors are important to address the human rights issues of access to mental health care?
I do believe that this is a human rights issue that is being, or is trying at least to being addressed by different stakeholders. A lot of NGOs are actually trying to help in this situation when you get all these inequities in the healthcare. As far as the psychologists, I know that some of them have been trying to reach out to those in rural communities. There are different programs that try to help to get access to healthcare in a more universal way. I can talk about specifically Partners in Health. When I was there, we used to work with a psychiatrist who studied in Harvard, and he has a book published that is called Where There's No Psychiatrist. So this is a way to implement healthcare specifically that for those who are in marginalized and vulnerable areas. And it's just a step-by-step guide of how to implement a brief analysis of those communities and how to implement a healthcare system that is specific for their brain health and their mental well-being. And we used to have access to psychiatric residents of Harvard that would help us with the hardest cases. And we also had the advantage of, even though that we were in the outskirts of Chiapas near the mountains, we had the NGO, Partners in Health. So we actually had access to antidepressants, for example, that a lot of the people who would be in a different situation, that would be in a different community in the same situation, but without the NGO, without Partners in Health, they wouldn't have access to these medications because these weren't paid by the government. This was paid by the NGO. So this, I think that as far as I know, the NGOs are the ones that are taking this, trying to build a fair world and to end the barriers that prevent to get equity in brain health.
So I'm sure.
Yeah, another.
Yeah, please.
Sorry, continue.
Yeah, Sarah, just thinking.
Okay, so also when we talk about human rights of mental health care, something that recently happened in Mexico is that trying to reduce the stigma of these patients, they try to include them in the attention of general hospitals, meaning that the hospitals that are dedicated to mental health care are aiming to reduce the attention and try to give more attention to the general population, not only mental health care problems. This was very debatable because the healthcare system is not ready to include them as patients in the rest of the hospitals. Most of the healthcare workers don't possess training specialized in healthcare and mental health care. So that means that we're not ready. As Aníbal was saying, we are still in the part in which we need to try to provide medicine for these people. We need to provide education. We need to provide programs that reduce the stigma and reduce the impact that the population has when they are living with a mental health care problem. So as it seems that we are trying to go from the big things to the small programs, but actually it should be on the other way. We need to start with the small things and then build up.
Mm-hmm. Yeah, I understand. And also, I mean, I wanted to ask you that, Anil, you mentioned that there is 2.7%, like what, 3 or 2.7 or 2 psychiatrists per capita. So, and which goes like one psychologist, 130,000. Just the gap is huge. So the whole gap is huge. What do you think as a medical doctor, both of you, what do you think that what could be the measures can be taken to mitigate, to reduce this gap? I understand that it is a huge country and it's a huge populations, but as Sarah said, that we have to take smaller steps to get into it. So what do you think as a medical doctor who would suggest that these are the certain methods that needs to fill in this gap or reduce this gap? What could be the reasons behind that?
I think this is a really complex issue, actually, because of course, like as I was saying, in some places it's as low as not even one psychiatrist for a whole state. For example, there are 2 big national institutes of psychiatry that are in Mexico City, and they are both in the same block. So there's a joke among psychiatrists that about the higher degree specialty psychiatrists, college psychiatry, psychiatry, all these, almost 99% are concentrated in the same block in Mexico, because they all study in those institutes and not in the rural areas. But why does this happen? It's because of the healthcare inequities, as I was saying, but also security. Because as a medical doctor, you are not safe enough, sadly, to be able to work in different rural areas where there are different drug lords are running the places. So there have been attacks against the medical community in these rural areas. So that's why, since the government cannot provide enough safety for this for the doctors, that's why they don't get access there. So that's one part, security. The other huge part is funding, because you don't get the same funding in Mexico City as you get in Chiapas and the different part. Why? Because of the broken healthcare. Because since it's so segmented, as you saw, this image is quite complex, even for us Mexicans to navigate it, it's really, really complex. So because there's this inequity within the funding, if you have the funding of a city or the funding of a rural area, then you also get the same with the amount of psychiatrists, psychologists, or different healthcare specialists in the different areas. So I think it's a really, really complex system that has to do with the current situation in the country as a whole. As far as solutions, I think that there could be some. For example, try to identify the barriers that are preventing this patient to get this healthcare and the bottlenecks, because there are a lot of bottlenecks within the healthcare system. Whenever they try to navigate it, then you get a lot of patients getting stuck trying to pass through a tiny space, so you get bottlenecks. So you need to identify those bottlenecks, try to do something that would widen them and be able to make it more fair access. For example, telemedicine. Telemedicine has been shown to help where a psychiatrist gives the help to the GPs or the consultation themselves via telemedicine. And as Sarah was saying, I think education is paramount. And you have also to normalize the education in healthcare and brain health in the different universities, because of course there are large universities that have doctors that are well prepared, but then in those states who are poorer states, they don't have the same quality in healthcare, but also in education. Why? Because you don't get enough fundings to the state university, and you don't prepare the professionals with the same quality as the ones in the city. So I think it's this complex system that has to be managed in a more broad way.
Yeah, so you mean to say that it's the education disparity that exists within the disciplines of healthcare system that is one of the major barrier in actually mitigating these issues. And I totally agree with that. And one more question that I had in my mind is regarding that older adults is one of the vulnerable population, which tends to suffer from a lot of psychological issues, be it stress or depression. There's so many psychological issues that exist. And I believe that the living status in Mexico of the older adults is also very fragmented. People are leaving the city and they're all alone. If that's so, how do you think that since already the professionals are very scarce, how do these older adults issues of a psychological issues are being dealt with currently?
Well, it's a very sad question to answer, because in Mexico also the geriatricians were lacking, as in many other countries. And in recent years, they tried to change the scheme for training, aiming that more people will get training and they will choose to do geriatrics. So they changed the program. That could be one way to do it. But when we talk about mental health problems in the older population, we face many other challenges, especially the normalization of them, because people will think that it's because it's old, because the patient is old, or they will think that it's because they have other things going. You know, there's also the social explanation. Oh, it's because his son had a fight, or it's because this person said something, or it's because he doesn't have money. Like, they will try to explain. They will try to explain since their knowledge. No, people will try to provide an explanation from their own knowledge. So that means that the population needs to learn more about it. And in general, because this problem might be happening since they were in their early 20s, for example, and they live with this mental problem their whole life, and then they reach the older stage of life, and they will be like exacerbating the symptoms, and people will be like, oh no, it has been always like that, so we don't care, or we don't put attention to it. So yes, we are aiming to train more geriatricians in the country, but still we are not yet in the position in which people will understand that mental health problems happen in all stages in life, and that is not due to aging, and it's not due to any other situation happening, that they should go to the doctor to receive attention.
I get your point in that way. So, I mean, as a geriatrician, if a person is coming to you as an older adult and is suffering from depression, so do you have that have that sufficient kind of any human resources or a services to refer them to some kind of a counselor or a psychologist or a person, or it's just that you deal more with the medical therapy because there is anyhow a lack of people there? Is it that way?
The short answer will be no. So if another person comes to me for attention and they're living with depression and other problem, I will try to address the problem. And then the next step will be a referral to a specialist. Then we face the challenge that people will say, oh, I don't want to go to the psychologist. I don't want to receive therapy, or I don't want to go to a psychiatrist, because that means that I am crazy. That means that I am wrong. That, all these ideas that are around mental health diseases. So there you face a challenge with the person, with the patient. And then when some of them accept to be referred, as I mentioned before, the referral system, it's very complicated because the healthcare system is very fragmented. So yes, they could get lost. And also, so okay, imagine that they go to the psychologist and all that. In general, the healthcare system is very saturated. So that means that few psychologists are seeing most of the patients. So they are not going to receive the proper attention. That means that they will need to pay for therapy from out of their pocket. And big part of them are not willing to do it.
I see. Get your point.
Yes, and I would also add to that question that it really depends on where you are. Because, for example, in my private practice, I would be able to refer a patient to a private psychologist or a private psychiatrist if I need to, no hesitation. However, if I'm in the, for example, as I was saying, in the formal sector in IMSS, then I would be able to send them to a psychologist. It might be a long wait, but I would be able to. But if I'm with the informal sector that was used to be covered by the popular insurance, I wouldn't have access to any kind of psychologist.
Mhm.
Or I would be with probably trainees or something that could not be perpetual in the care. It would be something like usually an NGO trying to help or a school trying to have their trainees do a clinical rotation, but I wouldn't be able to have a constant access. So it would be really hard. And in my university, doing my geriatric residency, we used to work in both private and public sector. So we had the advantage that we could learn the best from both, but we also had the disadvantage that we had the worst of both worlds. So it was really frustrating when you know the kind of healthcare that this patient would need to improve their brain health, and you wouldn't be able to, because of economical reasons, to send them with the proper person. So I think that's the part of the human rights that we were discussing earlier.
So it seems like it's the challenges are more than the facilitators, I guess, in the whole situation. It is like from the stigma to the human resources to the training. I think it exists in like a hierarchical way, and I guess it's a very fragmented system that I can understand by now. There's a very good question that I wanted to ask you, which is there in the chat box, which is in Mexico, implementing the WHO quality rights model of mental health care that focuses on how to increase access by, among other things, increasing the involvement of lay people and civil servant in mental health care. If any one of you can want to comment on this.
There have been some efforts to get more people involved in the in this kind of treatment. However, they have not been successful, and because of the heterogeneity of the system itself, it's quite hard to make the standard of care homogeneous, because you don't have the same access to the same tools or to the same specialists, or even to the same facilitator who would prepare the layperson to give this kind of attention. So it's quite hard because of the way the system is built. So that's why there has been years where different stakeholders or different professionals, such as I mentioned, Julio Frank, who are trying to implement a universal healthcare in order to unite all of this fragmented system into one. Because a huge issue, as you could see, is that if you are within one of these groups, you cannot access the other group. You cannot access, like, for example, the institutes, because you cannot access an institute if you have social security or if you have so it's really, really complex, and it's really hard to navigate it, and this is another barrier to the implementation of such quality of care.
That eventually trickles down that you cannot integrate the public health system, like the layman person, because that can help you to mend the fragmented healthcare system that is existing, but that is also one of a struggle to integrate the primary with the existing healthcare system. It's again a system of that. I'm very keen on asking questions on dementia, but because of paucity of time, I'm going to ask you one question is, can you please explain what normalization of dementia means? What is the role of family caregivers under the normalization of dementia? That's a really interesting question.
Yes. So when we talk about normalization of dementia, we don't talk about saying, oh, having dementia is normal. And people will live in the same way they have lived their whole life. What we're meaning is that people understand that dementia is something that happens sometimes, and it's part of life sometimes, and they are aware of it. So when they are aware of the disease, they can cope with it. And also they can help other people living in the community that has dementia. So for example, when we talk about a place that is dementia friendly, means that maybe if it is, I don't know, a bank, that means that all the employees in the bank know about dementia and will know how to treat a person living with dementia. And if something happens, maybe a behavioral thing happening in the bank, they will know how to cope with it. So for them, dementia is something that happens and they are aware of it and they know how to treat it, or they know how to cope with it. So it would be ideal if we could live in a world in which everyone knows about dementia and knows how to treat people living with dementia. And they also help them maintain their independence as long as possible. So that means that a person living with dementia can live in the community if they want to. They can stay in the same house they have lived their whole life in the same community if they want to, and the community can help them to be part of their own of their community life. Maybe going to church, maybe going to the supermarket, maybe being with the grandsons of the family. That would be an ideal world, which there's no country that has reached that stage. Yeah, that would be the last stage of acceptance of dementia.
So it's basically, in summary, creating a kind of a dementia-friendly societies where people are quite aware of what all the symptoms are and what are the consequences and how the society should be aware of their symptoms and get integrated into a normal society. That could be normalization of dementia. That's what is it?
Yes,
Okay.
that is correct.
That's amazing. That's amazing. That's great. Really, it was really an interesting interaction with you guys and discussing about dementia, vulnerable populations, and psychological role from a medical doctor, and the real reasons behind the healthcare system, the fragmented healthcare system. It's really, thank you so much for giving this information. So over to you, Dominic.
Thank you for having us.
Thank you so much for joining us today. We are very happy that you were able to participate with us. We tried to answer as many of the questions as possible, but I'm sure there were some questions that we did not get a chance to get through. So thank you for your patience with that. Please note that the recording of this webinar will be posted on the ICP website. Please be aware that we do have future webinars coming up. July 10th, we have one that's going to be taking place. And we have August 14th and September 16th. So we hope that you'll be able to join us again. And again, thank you so much for joining us. And your certificates will be in the email as soon as they can. Thank you again for our participants, and we really look forward to seeing you in our future sessions. And we will be leaving shortly. Thank you.
Thank you so much. Bye-bye.
Bye.
Thank you.